Okay. Hello, everyone. And on behalf of the Society for Surgery of the Alimentary Tract Research Committee, welcome to the webinar entitled The International Experience with Robotic Surgery. I'm Saj Khan, and I will co-moderate this session with Dr. Pooja Kaitan. We're thrilled to have you join us today for a discussion on the global perspectives of robotic surgery. We have an outstanding lineup of speakers from the SSAT chapters from Germany, Brazil, India, and the United States who are international experts in robotic gastrointestinal surgery. Over the course of the next 45 minutes to an hour, we will hear about the unique circumstances which are at the forefront of surgeons around the globe who perform robotic surgery. Each of our esteemed speakers will give their presentation with a brief opportunity for Q&A after their talks and also between their talks. Please make sure to put your questions within the Q&A button on the Zoom link here. And then Dr. Kaitan and I will ask some questions, we'll address your questions towards the end for our speakers. So to move along, so in the research committee, we are fortunate to have committee members who are members from the international SSAT chapters across the globe. And that's a very rich part of our committee and a great part of the SSAT. So that's been a really big plus and has allowed us to get all of our esteemed speakers here today. So as part of our webinar, our committee members will introduce speakers from their respective countries. And to start us off, Dr. Vikram Kate, former SSAT president from the Indian chapter of this SSAT, will introduce our first speaker from India. Dr. Kate?
Thank you very much, Dr. Sajid. And good morning, good afternoon, and good evening, depending on the time zones to everybody, because it's good evening right now in India. And it's my pleasure to introduce Dr. Vivek Bandal, who is the present president of the Society for Surgery Alimentary Tract India chapter right now. And he's a good friend and colleague. Dr. Vivek Bindal is Director and Head of Department of Institute of Minimal Access Bariatric and Robotic Surgery at Max Super Specialty Hospitals, Noida, which is close to Delhi. He's also got a fellowship in robotic GI and bariatric surgery, University of Illinois at Chicago, and is ex-faculty member of Duke University, USA. He's also been conferred the prestigious International Scholar Award by American College of Surgeons and is presently the chairman of Clinical Robotic Surgery Association of India. He's also on the editorial board as an associate editor of Journal of Advanced Robotic and Innovative Surgery, Journal of Bariatric Surgery, and also some of the other journals. So if you're a present Dr. Vivek Bindal, the most appropriate person I feel from India to speak on his experience on robotic surgery. Dr. Vivek Bindal, please. Thank you.
Yeah, thank you, sir, for the kind words. And so Miss Henry is going to share the presentation on a video, and I'm here to answer any questions. Thank you. Hello, everyone. I am Vivek Bindal from India. I'd like to thank SSAT and the moderators for giving me this opportunity to speak about the perspective on robotic surgery from India. I currently lead the Indian chapter, and we'll basically talk about how robotics is shaping up here. So we know, like the lunar mission. So India, or the Indian Space Research Organization, has been pretty thrifty with the expenses, and it has had successful lunar missions at 1/6 the cost of NASA. So ISRO spent like $75 million as opposed to $582 million by NASA. And we became the first country to land on South Pole of Moon. So India has, that kind of technology which is very cost effective, the way people have been using here. So a bit about my experience. I've been using robotic systems since 2010. It started with S platform, then SI, then X and XI. And there is this robot called the Mantra, which I've used. This is an Indian robot. I've also used the Bond Symphony, which is a new system. Medtronic, Hugo, and CMR Versus also have been used, and all of these are commercially available. So we have a lot of experience with new robotic systems. So globally, we know that a lot of robotic platforms are getting added every year, mostly in developed economies. Low and middle income countries have limited access to this platform, and the limitation is because of capital cost, because of disposable cost per case. Trained surgeons and OR staff are difficult to find. Society is not aware about this modality, and most of the payers do not reimburse for robotic surgery, but it is changing. Why do we need robotics? So, everyone is entitled to safe surgery, whatever the financial status is. So, if a platform can provide safety or faster recovery, early return to work, then it should be done for a particular person. So this is diagram showing the installation base across the globe. We have approximately now 10,000 robot systems across the globe. Asia has around 1,400 systems as of now. It is the fastest robot growing market in the world. And this is the procedure trend by category. So general surgery right now is number one. Earlier urology and gynecology were in the lead, but now this is the worldwide data. But when we look at the Asia Pacific, still urology is on the top, although general surgery in last year in India has basically overtaken urology and become number one in India as well. So we have 16,000 Asian surgeons who are intuitive trained, although there are other systems which we'll talk about. The first Indian robotic surgery was done in the year 2002. And, right now we have around 300 plus robot systems. This is again the specialty wise adoption, urology being one of the major adopters, but general surgery has picked up a lot. And we have now 300 plus installations across the country in all the states and all the tier 1 and tier 2 cities. And the cumulative procedures have been growing geometrically. So this is the Da Vinci Xi system, fourth generation intuitive system. I'm sure a lot of you have used this in your practice. It has staplers and advanced energy, boom mounted arms, and maximum installation experience worldwide. We do not have DV5 as of now in India or in Asia for that matter. This is just a small video of, hands-on gastrojejunostomy in a super obese male, uh, a bariatric surgery using a robotic platform. So this is how the robot is docked, and the targeting is done. So we have been using robotics for bariatric surgery for last 15 years now, with super obese and super obese patients uh, getting it, very frequently. This is a snapshot in the OR, and we basically use the sure form staplers to create the gastric pouch. This is the perigastric dissection. Um, and Sureform has the ability to articulate and angulate with 120-degree cone of articulation, and then we do a hand-sewn gastrojejunostomy. So this is division of the, after the fourth layer of GJ has been done, we are opening up the stomach and the bowel, and then we do a four-layered hand-sewn GJ. So not going into these technical details, coming to the cost estimates of this system, XI is approximately 1.5 million US dollars in India, and there is this X system which is cheaper, which is around 700 to 900,000 US dollars. The disposable cost per case is approximately $1,000 for this. If you use a vessel sealer, it is around 1,000 extra dollars, and staplers again is $1,000 for 5 to 6 reloads. Then there is this SS Innovation. This is a new robotic system. This is a made in India robot. It has open console. It has modular arms, separate arms which come in, a vision cart which has a 3D vision, and it has a lot of instruments, including a harmonic scalpel, and it is also made for cardiac surgery. The innovator, or the founder of the company, is a cardiac surgeon himself, and it has a multi-fire clip applicator ultrasonic device. It has more than 50 installations now, and the cost of Mantra is approximately half or maybe 40% of the intuitive system. The capital cost and the procedure per procedure cost is approximately 40% of the intuitive cost. So that it is economically much more viable. It is rapidly increasing, and a lot of other countries also have gotten licenses for Mantra. Now, this is another system called the Bonds Symphony system. It is again an open console system. It has a surgical cart with two arms, a tool driver robot, a lens driver robot, and a console with a 3D system, 3D vision. So it has both 5 mm and 8 mm instruments. Uh, 8 mm are endo-wristed, 5 mm are straight stick-like, and we have done phase 1 and 2 clinical trials for this, completed 60 cases, and now it is up for regulatory approval. So this is how it looks like. Uh, just a small video showing from outside the arms, how they are unfolding, and how the robotic system is stocked. So this is again doing a bariatric sleeve gastrectomy, and this is the open console. This is a system which also has a harmonic scalpel. So this is the gastrolysis, and then this is the suturing. So it is, a very good translation of movements. Uh, so this is another option here, which is again economically better off. Uh, some of these uses have been published in journals, and it has also been covered by Nature. Now, Medtronic Hugo again is a system which first got launched in India worldwide in 21, and it has, we have been using it in labs and in patients. It has now 70 plus installations across the globe, and it basically, has modular arms and open console. We have 6 active clinical sites in India, and the pricing is approximately 1 to 1.5 million US dollars, and consumable cost is $1,000 per case. So, these financial models would differ, but just to give an idea, I've just put these figures together. CMR Surgical is, another system which was actually the first competition to Intuitive in India, started again in India worldwide in 2018. This was one of the first installations in 2019, and it has open console. It is approximately $1 million now, but it varies a lot depending on the financial model. So these are the options, and with all these options, we need, we have multiple different teams of robotic surgeons who are working in India. We, when we talk about how to build up a robotic practice, we always say that one should have a team training. We should visit centers of excellence. Initial cases should be proctored for safety, and we should get connected to the professional societies like SSAT. And surgeons should try to follow the laid out pathway, and we should have our team travel together, and having a debriefing session after every procedure is very important. We also need to create awareness about robotic surgery in the physician community, and in your in your billing staff, in your insurance staff, and department coordinators. So because once they know, only then the patients or the other people will be knowing as to what is being offered. And in the operating room, we have to be efficient. We have to reduce in between case times. We have to use efficiently the instruments, because every instrument is chargeable, and we can do some procedures hybrid. So some parts where robotic does not have a lot of advantage can be done laparoscopic, and then robot can be docked for the area where it is most advantageous. Now, insurance in India is covering robotic surgery by this circular, which was issued in 2019, and another recent circular in 24 has directed all the insurance companies to cover for robotic surgeries and advanced treatment modalities. This is a summary of all the insurance companies, I think, and the government schemes. So these are pathways how to get your patient through this maze of insurance. I think this is useful for Indian surgeons, so just showing it for them. But otherwise, uh, yeah, these things are different for all the countries. Now, for overcoming economic hurdles, I think we need to develop indications for robotic surgery in our own practice. Certain robotic procedures are cost neutral to laparoscopy. Like if we talk about ventral hernias, laparoscopic ventral hernias, we typically use dual mesh and tackles, which are more expensive. In robotics, we are able to do extraperitoneal repairs. So we save on the cost of dual mesh and tacker, and it makes it cost neutral. So there are certain procedures where the stay of patient also reduces significantly, and they actually make it cost neutral. We also have a strong medical tourism industry which also fuels some of these cases. And if our insurance and billing staff is educated enough, they can guide the patients and get the robotic procedures reimbursed. And but why do we need robotics in our practice? So there are patients who are demanding option for robotic surgery. It is also a differentiator from competition. If you are doing robotics, it increases your ability to perform more complex cases. Like in bariatrics, you can deal with super obese and super obese. In abdominal wall, you can do recurrent hernias and large ventrals. And there is also a lot of potential of artificial intelligence and telesurgery in times to come, which we are going to see in this field. So I particularly like this statement. Doctors with artificial intelligence will take away jobs from doctors without artificial intelligence. So, it is not that AI is going to take away jobs, but if we adopt AI, we can increase our practice and we can definitely, make a positive impact. This is me discussing robotic surgery with our Honorable Prime Minister, who is a very visionary leader, and he actually foresees the growth of robotics and AI in India. Thank you so much for your kind attention. This is how the OR of future may look like. There may be no surgeon or anesthetist, and we may be just sitting in our room controlling procedures using an iPad. Thank you, and I shall be happy to take any questions.
Thank you, Dr. Bindal. That was very comprehensive and very thorough presentation. I would open up the questions for the audience if anybody has any questions.
Thanks, Dr. Khetan. I think the slides were blurry for some, but I hope that the message was put across. So that was the first question, in fact, that the
Sure.
slides.
I don't see any questions in the Q&A session, but I will ask a question myself. How do you address the challenges of starting a robotic system? I assume Mantra would be much more cost effective, especially the cost challenges that patients ask, compared to a thoracoscopic or a laparoscopic case, with the cost must be much lower. How do they compare, and how do you ask the patients to pay for the price of a robotic case?
Actually, that is one of the most important questions, and that is why economic feasibility or viability by all these different platforms which are new is important. So many times the patients are insured by companies which pay for robotic surgery, and the insurance regulator of India has very clearly mentioned in their documents and directions to the insurance companies to cover robotic procedures for all the patients. So that actually takes away the trouble of having someone to pay out of pocket for the robotic procedure. Although the procedures which have clinical value, which is established by using a robotic system, would be definitely easier to get reimbursed from insurance company. And uh, there are a set of patients who can pay uh, for the robotic system, and they would themselves want a robotic surgery to be done. But yeah, having said that, I think this multitude of new robotic platforms has increased the access of robotic surgery to a lot of tier 2, tier 3 cities in the country. And I think in times to come, we are already seeing a tremendous decrease in costs here, and we are going to see them go down over next few years. Yeah.
Great. Now I'll ask Dr. Khan to introduce Dr. Edelnath on behalf.
All right. Excellent talk, Dr. Bindal. Dr. Francisco Tustami is one of our research committee members from Brazil. Actually, he's stuck in transit, flying from one country to the other. So So he's not going to be able to introduce Dr. Edelmith. So I'll introduce Dr. Edelmith on Dr. Tustumi's behalf. Dr. Rodrigo Edelmith is a distinguished surgeon from Sao Paulo, Brazil, currently serving as the coordinator of the surgery program at Hospital Albert Einstein. Although a leading private hospital, Albert Einstein is founded on a charitable mission and plays a crucial role in Brazil's public healthcare system, providing high-quality care to patients through the National Health Service. Dr. Edelmith completed a 2-year research fellowship in New York City at Weill Cornell and the New York Presbyterian Hospital. He also pursued a postgraduate course in surgical leadership at Harvard University in Boston, USA. And today he will share insights on the collaboration between Brazil's private and public sectors, focusing on education and robotic surgery in public health institutions. Dr. Edelmith, I'll hand it over to you.
Good morning, everyone. Thank you very much for the presentation. So good morning, because it's 11 a.m. here in Brazil. I would like to thank SSAT for this invitation and congratulate my fellow colleagues for being here. Can everybody hear me okay and see my slides?
Yes.
Perfect. So I have nothing to disclose. Just a brief summary on Brazil. Brazil is a huge country. It's the 5th largest country by area and the 7th largest country by population, with over 200 million inhabitants. We are here in São Paulo, which is Brazil's largest city, with over 12 million people, and the greater São Paulo area has over 20 million. It is the biggest city in the southern hemisphere. Our hospital is called Hospital Municipal Vila Santa Catarina. It's a public hospital that was inaugurated in 2015 as a general hospital. We used to do hundreds of lap colis, transplants, and labors in here. Again, it is a public hospital. So we originated as a joint initiative between Albert Einstein Hospital, our private brother here in São Paulo, the federal government, and the city of São Paulo. But since 2019, we switched paths and started being a cancer center. We have nowadays around 200 beds, 20 ICU beds, 8 operating theaters, and perform around 280 procedures per month. We do have here in our public institution one Da Vinci X platform. It used to be the SI, and then last year it changed to the X. Our hospital is the 2nd hospital in the city of São Paulo and the 4th in the state in terms of number of oncology cases. So we do receive over 200 patients a month for oncology treatment, and nowadays we have around 12,000 patients under our care. We received our Da Vinci platform, as I said, the SI, in 2021 as a donation from our private institution, Hospital Albert Einstein. We started very slowly with only 80 procedures performed in 2022, but the number rapidly increased. So in 2023, we performed around 200 procedures, and last year, 261 robotic surgeries. That's around 7% of our procedures that were performed robotically. There are only 5 public hospitals who have robotic platforms in Brazil, and we are the first and only hospital from the city, public city hospital, to have this technology. We were also the first public hospital to perform a bariatric procedure. With the exception of head and neck and cardiac surgery, all other surgical specialties use the Da Vinci in our place. The colorectal team and the urology uses it the most, colorectal especially for rectal cancer, but we also do perform some gastrectomies, Whipple procedures, hepatectomies, and of course, bariatric procedures. As I said, urology uses it quite a lot for prostatectomies, but most remarkably for retroperitoneal lymphadenectomies. Last year, we performed around 14 or 15 retroperitoneal lymphadenectomies for testicular cancer, and that's been among the world's largest center for this specific type of procedure. So that's very honor for us. We divided the Da Vinci use, since we only have one in our hospital, for each day of the week for each specialty. So that way everybody can use it, and we usually use it for 1 or 2 patients per day. Of course, cost is something that matter for us. It is a major issue, not only for us, for the whole world. And we are a public institution, so we have very limited budget. We do not use any advanced robotic instruments such as the vessel sealer, synchroseal, or even the robotic stapler. And clips as well, we do not use robotically. Instead, the bedside surgeon uses regular laparoscopic, bipolar or harmonic, ligature Maryland or ultracision, and it's the same for the stapling devices. The bedside surgeon uses laparoscopic regular stapling devices. In our institution, both public and private, we also do not perform robotic cholecystectomies due to the costs and to the gold standard practice, as we know that laparoscopic cholecystectomies are performed with minor adverse effects, and the patients usually go out, they have the same day discharge. But how is it possible? I'm here to talk about robotic in the public health. How is it possible for us to have a robotic platform in a public hospital? This was only possible for us because we have a private-public partnership with Albert Einstein Hospital. That is our private institution. Albert Einstein Hospital was founded in the mid-50s by the Jewish community as a non-profit organization. We were the first hospital outside the US to receive the Joint Commission accreditation, and we are among the world's best hospital for the past 6 years, according to Newsweek. I'm very happy and glad to say that just yesterday, the new 2025 Newsweek ranking was released, and Albert Einstein is now in the 22nd position. We were 28 last year. And our institution has a purpose, and its purpose is to provide healthier lives, bringing a drop of Einstein to every human being, regardless of where they are, if they're public or private. So that is Albert Einstein's purpose. So most people who hear about Albert Einstein outside Brazil or even in Brazil, they remember us as a private institution. But actually nowadays, our ecosystem, our health ecosystem is way bigger than that. Yearly, we treat more public patients in Brazil than private ones. So you can see that last year, this is actually 2023, we treated more patients in public hospitals than in the private sector. We also do have more beds in the public sector than in the private sector. And this is out of date because last year we got 3 new public hospitals as well. So we need to update these numbers. And this is why our system works. And we do believe that it is our duty as a leading health institution to foster and drive innovations. That is why in 2008, we started our robotic program. So we are only here today because back in 2008, our board decided that we would invest in a robotic surgeon to be a pioneer in the field. So we acquired the first Da Vinci platform and performed the first robotic prostatectomy in 2008. But from 2008 to 2017, everything went very slowly. But since 18, really gained center training for intuitive. And in 2019, we created a one-year post-graduation course to train young surgeons from all over Brazil and also Latin America. So because of that, in 2021, we were able to donate from the private sector to the public sector the Da Vinci SI platform. Our robotic cases, both private and public, increased over the course of these years. For the past couple of years, it really skyrocketed. And last year, we performed around 2,400 robotic surgeries only in our ecosystem. Today, we have Latin America's biggest robotic park. So in the private sector, we have 3 Da Vinci Xi, 1 SI that is going out it just went out last month, 1 X platform. We do have the only Medtronic Hugo in Brazil and in Latin America, if I'm not mistaken. Some orthopedic robots we do have as well. In our affiliated private hospital in Goiânia, in the center of Brazil, we also have 1 Xi. As I told you, we do have in the public sector 1 Da Vinci X, and we are the only center to have a specific training center for robotic with 3 dedicated SI, X, and XI for the training of surgeons and residents. Just last week, we got Anvisa's, that's FDA's, by Brazil's FDA's approval for the use of the Medtronic Hugo for GI surgery, because last year it was only allowed for gynecology and urology. And it was a bariatric procedure and the biggest BMI for this platform all over the world. The patient have a BMI of over 50 and we use the Da Vinci with him. So the post-graduation degree, we already trained over 500 surgeons in all fields: urology, gynecology, colorectal, upper GI, and head and neck. But not only in Brazil, something that really helped us, we started a consulting program both in Brazil and abroad for Latin America, helping in the implementation of a robotic service in hospitals or even countries who don't have if they have the minimum requirements for the robotic, such as OR sizes, electric network, and so forth. Their team started, their team with the country, they come here to Brazil, they start an online module, then they come to Brazil for 4 or 5 days. They are here to see 10, 15 procedures. They also train at our simulation center. We have over 15 simulation devices in our hospital as well. And then we'll travel to their hospital, to their country, not only with a proctor, that's something that's really different, but with our whole team of specialties and nurses. We are not only there to train their surgeons, but the whole staff. We deliver much more than implementation of a robotic platform. We implement basic and quality standard and safety measures, like timeout before procedures. We take Albert Einstein's DNA and quality and safety measures to their place. We had a very recent successful case in Peru. That was amazing. We implemented the first robotic platform in their country. In the course of 20 days, they performed 30 procedures with 0 complications. We trained 9 surgeons, 4 nurses, 1 clinical engineer, and the whole pharmacy team. Just last week, they completed a total of 100 surgeries in 3 months. That's an amazing achievement for a public hospital in Peru. That last year, they didn't have any robotic platform at all. So they just published in their newspapers that they have now a robotic platform because of our help. Over the past 2 years, we have helped over 5 centers outside Brazil to implement the robotic system, and we are most likely to start new projects probably in Argentina and other countries in the course of this year. We have trained over 1,800 surgeons from over 16 countries, including Asia. We had one student from India that came, if I'm not mistaken, in 2020 or 2021. As a final message, when we talk about robotic surgery, especially in the public setting, everybody asks, but what about the money? Is it cost effective? But we must think of it not as a cost, but as a long-term investment. An example, in 1986, Albert Einstein, acquired the first MRI machine in Latin America. It was extremely expensive and only available for very few patients. You fast forward 40 years, in Brazil, we have nowadays more than 3,400 MRIs, both in the public and private sector. Robotic surgery will most likely follow this path. Scale will grow, costs will decrease. And again, we do believe that it's our duty as a leading health institution in Latin America and in the world to foster and drive innovation. Thank you very much for your time. I'll be more than happy to answer questions and connect with you. If you ever want to visit Brazil, visit our institution and our campus, I'll be more than happy to show you around. Thank you very much.
Thank you, Dr. Edenmuth. That was very insightful. What an interesting talk. I think it sounds like your team is facing some of the challenges that almost every institution faces when you first take on the robot with cutting corners with your stapling devices and energy devices. So kudos to you. I'll open the question Q&A. I don't see any questions in the Q&A box, but if any of the other co-moderators or panelists have any questions, please feel free. Otherwise, I'll ask a question. So Dr. Edenmuth, with this exponential increase in your number of cases, how do you plan to monitor your outcomes to say that these are comparable or more likely better than conventional minimally invasive approaches that we've all been using? Are there any
That's a great question. Yes, that's a great question, and it's a very tough, a very big problem that we are dealing right now. So in the private sector, we do have specific engineers and data analysts that are looking into our cases. So we do have that. We need to hire, of course, more analysts because we know in the long run, probably in a year or 2 years from now, we will be short-staffed. We do not have, so today, we're not looking at outside partners. So the such ones in Peru, Argentina, or Chile, we don't control their outcomes, only ours inside Brazil. But we do have dashboards and costs. We're analyzing that, and hopefully we'll publish that in the near future, but only within our institution, both public and private, but that we do have data on that.
Great. I think your presentation also underscores the importance of educating folks, not just educating ourselves, but even other disciplines, especially the non-surgical disciplines, about the value of robotic surgery to allow patients to come ask for that surgery, because I myself can confirm that, yes, there is value to robotic surgery itself.
Exactly. I think that's one thing that we really believe in, that we have to train not only the surgeon. So it's not that you have to send a proctor and they will teach you how to operate, but the whole multidisciplinary team. I think that's what makes the difference, because you might have the money and you have one robotic platform, but in the end, those patients are staying longer, having more pain, or even dying. So you have to change the whole culture of the institution, the hospital, not only buy the technology and leave it there.
Anyone else with any questions? Next, I'll ask Dr. Saj to please introduce Dr. Hay.
Okay. Excellent talk, Dr. Edelmuth. So I'd like to introduce our next speaker, Dr. Jin He, who's an associate professor of surgery at the Johns Hopkins University School of Medicine, and he's division chief of hepatopancreatobiliary and GI surgical oncology. Dr. He specializes in diseases and tumors of the pancreas, liver, bile duct, and gallbladder. He performs open as well as minimally invasive robotic and laparoscopic surgery, including the Whipple procedure. Dr. He is one of the leaders of robotic pancreatic surgery in the United States. Dr. He received his medical degree from Beijing Medical University and a PhD in oncology from Fudan University's Shanghai Medical College. He completed a general surgery residency and a complex surgical oncology fellowship at Johns Hopkins. Dr. He is currently the John Cameron Professor of Alimentary Tract Diseases. He also does a lot academically, and he has a research focus on personalized treatment through stratifying pancreatic tumors on their genetic features. And he publishes extensively in journals and lectures internationally. Dr. He, looking forward to your talk.
Thank you, Dr. Khan. I'm going to share the slides, and I think there's some network issue. I'm going to stop my video here and only use my voice to just improve the connection here. Can you see my slides?
Yes, we can see your slides and we can hear you very well, Dr. He. That's great.
Perfect. Again, it's a great honor to join the SSAT webinar. Thank you for this opportunity. I'm tasked, in the next 10 minutes to talk about, the Hopkins experience in transition pancreas surgery from open to a robotic approach. I'm going to start with a few necessary things in building the robotic program at Johns Hopkins. I think the first and probably the foremost is about the support from your mentors. At least two mentors here, John Cameron and Chris Wolfgang. They play instrument role, more than 10 years ago when we started doing robotic pancreas surgery. We're truly standing on the shoulder of giants. Johns Hopkins is a historic place with very strong reputation in pancreas surgery. This is all started with Dr. John Cameron's work that he has put into this field for the last 50 years. So Dr. Cameron retired, a few years ago. During his life career, he performed more than 2,400 open Whipples. So he attracted a lot of patients to Johns Hopkins for pancreas surgery. So to start thinking about switching from open to a robotic approach, I think the first thing is you have to start it with a high volume practice to have senior surgeon support. In the beginning, when I started, I always started the robotic Whipple on a so-called easy case or straightforward case. But where do these patients coming from? I think without a senior surgeon support, it will be extremely difficult in the beginning for a surgeon to hop on the robotic approach. The hospital also need to have a vision to support this robotic platform. I remember in 2015 when I first started doing robotic Whipple, we only had one XI system. That was 2015. So I have to wait to get on the XI system to do a robotic Whipple. But now in 2025, 10 years later, we have more than 20 XI systems in the hospital. The majority of the systems have dual console, which is critical for the teaching of residents and fellows. So the hospital need to have this kind of investment. And obviously, you have to build up your own team. I have a very dedicated physician assistant at bedside to help all the setup. And, the hospital have the robotic coordinator to make sure all the robotic rooms has priority for robotic cases, not for open cases. So where the evidence for, a minimally invasive approach for, for when we started this program more than 10 years ago. So this is probably a very early paper published by Mike Kendrick in 2013. And for the first time, he showed, a pure laparoscopic approach, Whipple was associated with survival benefit for patients with pancreatic cancer. And because of these, because of Mike Kendrick's visit to Johns Hopkins, John Cameron and Chris Wolfgang started pushing, young surgeon like me to engage a minimally invasive approach. Now, over the years, we follow the evolving evidence supporting a minimally invasive approach. But the bottom line is, whenever we do any robotic pancreas surgery for patients with pancreatic malignancy, we always follow the same rule. So our philosophy at Hopkins is a minimally invasive approach for appropriate selected patient, hopefully will reduce complications, and therefore that we may contribute to their improved oncological outcome. So how do we do this? In the last 10 years, even in the United States, we've seen very obvious trend using multiple national database that more and more institutions are doing more and more robotic pancreas surgery. So it's an obvious trend. At Hopkins, we don't want fall behind and only doing open surgery. So that's another external force to push us to engage a robotic approach. Now, finally, in 2024, we have RCT data, level 1 evidence published in Lancet supporting a robotic Whipple is offering very similar outcome compared to open approach for patients with pancreatic cancer or periampullary tumors. So this is my setup in the last 10 years using XI Da Vinci robot. As I said in the previous slide, we always have a dual console in the OR. So myself and the trainee can sit together. So we have 5 ports for this pancreas surgery setup. And my PA is sitting in between the legs to assist the surgery. And so this is a pure robotic setup, which means every instrument, every energy device, except a stapler, was using the Da Vinci equipment. So the energy device I typically use is a robotic harmonic, and my assistant is responsible for instrument exchange and stapler firing, and all the anastomosis was done intracorporally. And in the end of the surgery, we'll make the assisting trocar big enough for the specimen to come out. To me, probably the biggest advantage of the robotic approach compared to laparoscopic approach is this is truly a one surgeon model that I can do the whole case with one surgeon. I don't need another second surgeon at the bedside to assist, which to me, it truly liberates the workforce for my team. And obviously, robotic surgery gave you the stable 3D magnified vision, especially with Firefly. You can use ICG to illustrate, the biliary tract, and the ergonomic setup is just, not comparable. I mean, doing laparoscopic approach, I've seen way too many surgeons suffer from occupational injury by doing, many years of laparoscopic surgery. So there are many obvious benefit of a robotic approach, but probably the most obvious one is this is truly liberating a surgeon from bedside, that you can do everything at the console. I'm going to use a couple of short videos to demonstrate the surgery principle of a robotic approach, that we don't cut the corner, that we do the high quality surgery just as we do for the open pancreas surgery. So this is a patient with advanced pancreatic cancer after chemotherapy. You can see the SMA and portal vein SMV was involved. but they remain patent. So our approach is to do a robotic divestment. So this is a pre-op scan. Again, after chemotherapy, you can see the tumor is abutting the SMA. Now, I use a lot of vessel loops. I use bulldogs to control. I use robotic harmonic to do the fine dissection. And the visualization, this is again 20 times magnified view. And you don't rely on a scope holder to hold the scope. You control the instrument all by yourself. So your assistant is only responsible for the suction. You see the suction coming from the assisting side, and also obviously control the instrument exchange. Let the video play a little bit and move quickly to the end. The goal of the surgery is to completely expose the SMA and do the divestment, get the artery exposed, and achieve the so-called triangle exposure. So you can see here the SMA is exposed. Again, with 20 times magnification, you can see the structure better than you wearing surgical loops for open approach. And sitting at this console doing this surgery is relaxing. And some surgeons claim they can do 2 robotic Whipples a day without suffering too much stress or muscle ache, or neck pain. So this is again obvious benefit for robotic approach compared to other minimally invasive platforms. You can see the SMA here is fully dissected on the right side and completely remove the tumor. So in recent years, we also engage more and more parenchyma preserving approach for benign or low malignant disease. In the old days, if those patients need a Whipple, now we're doing more and more duodenal preserving head resection. This is a really nice systemic review from Hans Berger, showing much less chance of new onset of diabetes, less liver steatosis, less exocrine function insufficiency. So this is another short video here showing the benefit of the robotic approach for IPMN, which was associated with chronic pancreatitis. And because of time limit, I'm only going to show you the final view of this surgery. So this is a pre-op scan. This young patient with multiple cysts in the head of the pancreas, and biopsy confirmed IPMN. And here you can see the dissection. Once you get the pancreas separated from the common bile duct here, and you will see all the vascular arcade to the duodenum to the bile duct was carefully preserved. And you can also use ICG to demonstrate the common bile duct, to demonstrate the real good flow to the duodenum. And you can see the arcade here, which looks nice. And also I inject more ICG to demonstrate the good arterial flow in this arcade. In the left upper quadrant, you can see the bile duct, and you can see the arterial flow in the arcade. Now, this is a very brief summary of our program from 2015 to 2023. The reason I stopped at 2023. 2023 is was the first year our robotic pancreas volume was higher than our open pancreas volume. And here you can see our yearly growth of robotic pancreas volume here. The red bar is Whipple. yellow bar is distal, and others are, all the other pancreas-related surgery, central, enucleation, duodenal preserving resection, or total pancreatectomy. This should look at my personal data for the first over 300 robotic Whipples. I look at last night. The number is 320 right now, with very reasonable fissure rate, 9%, DG rate 4%, and mortality rate is less than 1%. And also on the other different column here, I list all the published data from different groups across the whole world, including some randomized clinical trial data. So to maintain a good outcome is critical in building up the robotic program. Otherwise, you're going to draw a lot of criticism, say your robotic approach is not helping those patients, but actually increase the cost. Again, so constantly checking your outcome and try to improve is extremely critical, especially in a high volume center, to maintain this robotic program. And the team is growing. So right now I have 3 other partners also doing robotic advanced pancreas surgeries. All the fellows listed on the right side, after graduating from Johns Hopkins, they also starting robotic pancreas surgery in their own institutions. So in summary, what do we need in building up the robotic practice for pancreas surgery? I think we need evidence. Again, the evidence is pretty clear after 10 years continuous effort across the whole world. It's the most recent level 1 evidence suggesting, at least for the robotic Whipple, is as good as open Whipple. Volume is critical. As I show you in those bar graph, if you started the robotic Whipple program in a very low volume practice, it's going to take a very long time. The last thing is about the outcome. You got to constantly improve the outcome to make sure that this robotic surgery benefit is fully demonstrated. Again, in the beginning it may take some learning curve, but after you pass the learning curve, if you keep evolving and maintain a good outcome, and this robotic program will be recognized by your patients and by your referring doctors. I'm going to stop here and happy to address any questions.
Thank you, Dr. He. That was a wonderful presentation. We're going to save questions for you for the end. I'm going to get Dr. Keck on in just a moment here too, but we'll have time at the end for questions. Louisa Baum is one of our research committee members from the German chapter for the SSAT. I'm going to have Dr. Baum introduce Dr. Keck.
Thank you so much. I have the honor to introduce my department chief and also long-term mentor, Professor Tobias Keck. He's been leading the department at the University Hospital in Lübeck for more than 10 years now, trained in Freiburg and Heidelberg in Germany before, was also a fellow at Massachusetts General Hospital. So he has really pioneered minimal invasive and later robotic surgery in Germany. He has built a very strong, structured robotic training program at the hospital in Lübeck with other members of the surgical team. It's called Robotic, and really allows senior residents and fellows to approach robotic surgery in a very structured way. He has also established a large training and research facility specifically for robotic surgery, LIROS, that has different robotic systems available both for training and for surgical engineering research and AI-based research. And he's also currently running the only robotic pancreatic surgery training masterclass in Germany that's endorsed by the EAHPBA. So we're very honored to have you with us, and we're looking forward to your talk.
Thank you very much, Lisa, for this kind introduction. Thank you, everybody, for having me. Can you see my slides? Do you see them? Okay, perfect. So my task was a little bit to talk about establishment of a robotic program in Germany. And as you know, we have a public healthcare system in Germany, so our resources are not redundant. We don't have a public funding so they have to come out of the daily business as far as funding. These are my disclosures. So in my talk, I would like to give you a little outline. I would like to talk about our hospital structure and the caseload that we are having, about our current robotic program and about the way how we get there, and about challenges for further development. So the University Hospital of Schleswig-Holstein, very hard to pronounce, is UKSH. It's the second largest healthcare provider in Germany after the Berlin Charité. And we have two campi, one is in Kiel and the other one is in Lübeck. So they are about 45 minutes to an hour apart from each other. And we are employing 16,000 people. The area that we cover is around 4 million people. We have 2,500 beds. We are treating about 70,000 patients stationary and about 180,000 patients ambulatory care. And we have a lot of cancer patients, and we are a certified cancer center. So this is what Luisa was talking about, our platform. So we have one platform, that's the UKSH. Those are both hospitals, Kiel and Lübeck. And we have also a Fraunhofer IEMTE, which is a research platform where we are purely doing non-operative research for robotic surgery. We have 4 Da Vinci systems available in the clinical system. We have one Medtronic Google system in the clinical use and one in the non-clinical use in the Fraunhofer. And we have 2 distal motion systems, one in the clinical and one in the non-clinical use. And we had an Avatera system. I don't know if you're familiar with it, the first German robot, but they filed bankruptcy because the robot was not really competitive compared to the other systems. So we got a big funding money from the EU, 3.5 million euros to establish like a training and research OR purely for robotic research and training. And this is how the OR looks like in the planning schedule. And we have several aims in this. So we use collaborative robotics in this platform. We also use motion capturing and AR and IR for capturing of team movement and also movement of the robot arms. And we have a huge platform of additive manufacturing, especially in the Fraunhofer, where we are producing siliconized organs for training and training purposes. So this is how the OR looks like currently, and it's a training center, a research platform. We're testing other like associated materials there, and it's a platform for technology transfer. So this you're probably aware of, everybody. So it's going steeply up. General surgery is the fastest growing market in robotic surgery, as you know. Also in Germany, it's the same picture. And where are we now? So now we have a pretty good running pancreatic program. We are national lead in Germany for the EMIPS. I don't know if you're familiar with that. It's a group of European surgeons led by Mark Wessling and Moabu Hilal. And we are gathering our experience in robotic surgery and trying to generate evidence from pooling our data together, and also conducting prospective randomized trial. As some of you might know, the Diploma 1 trial, and just in pipeline now the Diploma 2 trial for robotic versus open pancreatic surgery in a randomized control trial. This is the results from the Diploma 1 trial. You can see here that we have been testing minimally invasive versus open distal pancreatic resection, RCT, and showed it's safe and feasible. And this was just published in Lancet Regional Care in 2023. But we also look at proficiency and mastery of procedures now, and we're trying to establish data on how many operations are necessary. And especially in pancreatic surgery, we heard before that you need a very high caseload, because for proficiency, you need 56 procedures, and this is distal pancreatic resection, not pancreatic head resection. And you need for mastery 85 procedures So you need a decent caseload to do this. When we were then looking at the German data, this doesn't even appear here because the volumes were so low in Germany in pancreatic surgery that we were thinking we have to do something on a institutional level to spread the pancreatic surgery experience in Germany. And this is the GAPA search group. So we are gathering also the EMIPS data with national data from the US, NetScript data from the Netherlands and from the German Studok registry. And you can see here that in robotic surgery, overall in Germany, the amount of robotic surgery in 2020 it was very low. It's still not very much higher. It's around 4 to 5% now. Whereas in the Netherlands, by a structured training program, they were able to nationwide increase the amount of patients who do pancreatic robotic surgery. So this is our experience at the moment. So we do liver surgery and also pancreatic surgery. This is pancreatic jejunostomy and bulbar anastomosis that we are doing here. And you can easily see the advantages, as mentioned before, of robotic systems that are able to really define resect and reconstruction in HPB surgery. So we are pushing this also to portal vein resections, as is seen in this case, or as seen in this case for like a tangential resection of a portal vein, where we take out the thrombus here and do a vascular reconstruction in this case. So we're trying to push the field also for advanced cases in robotic surgery. Also, always with the consideration, of course, of morbidity and what having these cases. There's another example of pancreatic cancer. This is celiac trunk infiltration by a pancreatic cancer neoadjuvantly treated, and we do an Appleby operation. We use these probes from cardiac surgery here to measure the flow after excluding the hepatic artery. And when you have enough flow, of course, we can then go ahead and resect the celiac trunk and the hepatic artery because the flow to the liver is guaranteed by the anastomosis, reobronchial anastomosis via the gastroduodenal artery. So what were key factors to my opinion for our program? So we started not so long ago in 2016 with a robotic program. And from the first moment on, we included our residents into the program. So the theory is that, of course, we had as everybody has on-site introduction of Da Vinci, but we also did a virtual simulation and training program that I will show you in a while. So this is a 3-step program. We have had a program already for competency and proficiency in laparoscopic surgery. It's called a Lübeck Toolbox training. And we moved this to a robotic platform and looked how people can perform in this. And we were really astonished how easy people mastered these exercises with a low learning curve. So we had to find more difficult procedures, as here we used biotissue for anastomosis as one task, standardized task. And then in the end also we use torsos with plastinate organs for training in 3-arm operations for residents in a plastinate scenario. Then in advanced praxis, of course, parallel residents started, of course, as table assistants. We do not have PAs in Germany. It's not very common to have PAs. So for the residents, it's really good to see the procedure from the beginning. And I think it's a big step also to see complex operations and assist in them for the residents. We have a dual console, of course, to enhance training. So these are some results. The first step is a basic and VR training, as everybody does with the platform, and then we move on to the TriLab training, as I showed you before. It takes around 3 to 6 months for the residents to complete this. And then in the operation practice, so observation of robotic procedures, assisting of robotic procedures, and taking over steps in a dual platform, simple steps like cholecystectomy or other steps during the complex operations. Takes another 6 months. So what this does for our residents, to my opinion, is that they are always exposed to robotic surgery, either in assisting on the table or in training in these platforms. And they are really, when they come to a more senior level, very experienced with a machine and know how to drive the machine. So this is the simple box training as we did. It's a RAS-based basic skill training. You are sorting here some doing minor box training exercises for 3 to 6 months. And the advantage is they can do it on the platform in the OR, of course, of ours, but you don't use any tissue material from animals or cadaveric training, so they can do it on the same machines as we do our surgery the next day. These are plasticizer organs, so simple procedures like here, suturing an ulcer, or duodenal ulcer, so you have to use 3 arms of the robot to expose it and suture it. And then you have here a cholecystectomy in a plasticizer organ. And here you have a lateral gastrojejunectomy. This is actually the final task, the benchmarking task, where we define proficiency in these So this is, we can go over this a little bit. So we have video material in a cloud for all these exercises. So the residents know how to build the exercise themselves. We don't need a trainer available all the time. So they are responsible for the setup. And they're responsible for the exercise, and this is explained in video in the cloud. So we then, this is the last step here, step 3, operating room practice, where we looked at the simple steps during the procedure. So we tested this in several residents, and the key feature or benchmark exercise was actually this. So you can see here, this is a robotic gastroenterostomy in a model, of course, with a non-trained resident. And you can see that he is not very skilled. He doesn't use both hands. He does a lot of mistakes during the exercise. And this is here after the training. And you can see here, even though he has never done this exercise before, because it's only the benchmark exercise, just the training with a machine really enables him to master this simple exercise and show more proficiency than in other cases. We are now rolling this out on a German level. These are the exercises, and we are trying to put this into our society for training in all different hospitals in Germany, so we get the residents early on the machines. The second step that we did was a stepwise approach. When we started with a robotic system, we had the challenge that, of course, we just were increasing complexity over time. So we started with simple cases, cholecystectomy, atypical gastric resection, fundoplications, then intermediate operations like pancreatic left side resections, adrenalectomies, or left lateral hepatectomies, and then more complex operations. And by doing this, we kept our complication rate very low. So we had no problems in these 3 steps, increasing complexity. Conversion rates were, of course, low, and they were high a little bit in the last step. I'll show you why, because we started then with very complex procedures like Whipples in the early phase. We had a lot of conversions, preemptive conversions in these cases, because I'm convinced that preemptive conversion is not a problem when you don't do it in an emergency setting. For duplication, of course, no problems, and then Ivor-Lewis operations, a little bit increased mortality in the last interval, because we also increased complexity of these patients and reduced selection. So these are learning curves from the residents, assisting residents. So this is the time from the cut to the robot docking. So the first insertion of the port to the robot, and you can see here, they go very far down. Now they are down to below 5 minutes. And it doesn't really matter which resident does it, because most of them are trained in the procedure. This is robot surgery time. There's not much change because the procedure stays complex, especially pancreatic head resection is a complex procedure. And I don't know whether we can really go down with the timing, which we also, as seen before, a one-surgeon approach. So standardization of the procedure was the next point. This is an example for an Ivor-Lewis operation. We do also Ivor-Lewis operations. I think in the US, they are mainly done by thoracic surgeons. In Germany, they're done by general surgeons. So we standardize the procedure by different steps, and everybody is doing the same. Like here, lymphadenectomy, T2, and gastric artery resection, transidal preparation, and pre-aortic preparation. Then we can go very far. Then we switch the patient after we do this to a lateral position, and we insert the trocars on the thoracic part. And you can see here we do a preparation. It is the esophagus that you can see here. These are the branches to the aorta, and this is the arteriosus vein. These are the subcarinal lymph nodes that have to be removed during the Ivor-Lewis operation. And then you can see here cutting the arteriosus vein, and finally constructing the passage with a pull-up of the gastric conduit for the anastomosis. So, and then the next step was transfer to new systems. So we, as I said before, we have a Hugo system, and we were very, we didn't really know whether it's easy to transform our knowledge to the Hugo system, but it was quite easy because only the docking is a little bit different, but after some training, it was easy. So in the Hugo system, I don't know, some of you are familiar with it, but maybe not all. We dock each arm single, and we have to look at these angles of the arm that are a little bit tricky in the beginning when you start the program to really dock each individual arm. But once you do it, it's almost the same procedure. You can have the buttons are in the same area, so you can use your foot pedals as you used to do with a Da Vinci system. So the transfer was not really difficult. This is a case of a sigmoid resection. Maybe I'll show you the next one for the sake of time. This is a redo fundoplication with the Hugo. We have a limited platform of instruments at the moment, so we only have the bipolar coagulation and the monopolar scissors. We do not have advanced energy for these cases, but you can see here preparation is very similar to what we see in the cases with the Da Vinci system. So, but we do still, due to CE certification, you cannot do all operations. HPB is not possible with the Hugo so far. So the future challenges are national training programs. You can see here, these are the MIS data for pancreatic resections, and Germany is not really good in this comparison. So North American data here from the NESCRIP data show much better results, less complications, and also better results as far as fistula formation and delayed gastric emptying. So I think national training programs are at need in Germany, and we are trying to push this further to spread the experience and reduce morbidity and mortality in the patients, for our patients. It's the same again. So in summary, our approach really was looking at resident participation from the first moment on. We did a stepwise approach as far as coming from low-level, very easy procedures to more complex procedures. Standardization of the procedure pretty fast in the whole rollout of the program. Future challenges. I'm the upcoming president of the German Society for General and Visual Surgery, so we really have a big challenge to spread this on a national level without increasing mortality and morbidity, especially in very complex procedures. Therefore, we need also quality controls in some form. We need general evidence, and as everybody, we are also, of course, facing financial issues. So we use robots currently only for very complex procedures, or just for the easy procedures only when we do training. Thank you very much for your attention, and I'm very open for your question. Thank you.
Thank you, Dr. Kate. That was very enlightening. Obviously, you hit the very important points of mentoring and having a vision so that we can invest in our future residents and trainees. I'll open up the questions panel for anyone else if they have any questions to ask. It's open to all our esteemed speakers.
I might have a question for Dr. Heath. So how many people in your department do robotic Whipples? So we are really now at that point where we would need a second or a third search to do it. And I would be interested in how you are spreading the knowledge from one to the next one.
Yeah, so we have 5 HV surgeons right now. 4 are active doing robotic Whipples. Everyone has a little bit of different focus. They have different what we call a clinical FTE. But 4 HV surgeons right now are fully qualified to do robotic Whipples. We just cannot do 2 surgeons Whipple. That's why a physician assistant is critical to replace the surgeon at the bedside. But also, since we all have dual console setup, the trainee will have more opportunity to sit in the console to participate during the surgery.
Thank you.
Dr. Keck, I have a question for you. So you are obviously doing excellent work, you and your colleagues. Are there any patients that are not candidates for a robotic Whipple? I mean, you showed a nice video of doing a vein resection, reconstruction. Do you have any contraindications to doing any robotic Whipples?
Yeah. So these were just cases to show you that we are trying to push the envelope a little bit. So these are not our regular cases. I think it's a very good, if you have enough cases in your practice, as we do also, we are also a high volume center for pancreatic surgery, you can do very decent selection. And I think from my opinion, very good cases are periampullary cases or, for example, IPMNs or precancerous lesions, parenchyma saving resections, very good cases. And I wouldn't try to put this into public so everybody should do every case. So for example, if we know from advance that we have vascular invasion, we probably not choose for a robotic Whipple. We'd rather go for an open Whipple. If we facing vascular invasion, as in these cases during the operation, then we will not necessarily convert now. So we would go further. But I think there are centers who are more aggressive and also an indication than we are.
Wonderful talk, Dr. Keck. So, how do you train your residents, and would you consider a hybrid operation for people to start with, doing resection, laparoscopic, and then docking the robotic system for reconstruction? And what parts of operation would you give as the first parts to your residents to do for training?
So for the residents, we are always putting one resident on the table. So we don't have the PI, as I said before, though we don't have a surgeon on the table. Normally it's a resident. So they are familiar with the whole setup because they do it all the time. Setup of the system and also challenges, how to reach and everything. Once they are really experienced on the table as table assistants, they move on the assist console and they observe and they do minor steps of the operation. So, for example, cholecystectomy is a very good assisting procedure for training during a bigger operation or other aspects. So the dual console, I think, gives you opportunity to really let people go, and then we take over control after it's maybe too difficult and too complicated. We do have also some training cases, so we are filling the slots. If we have a 8 o'clock Da Vinci availability, we are starting with a Whipple or an Lewis operation, and then we have a little space left. Maybe we do a cholecystectomy or fundoplication or other cases that are more suitable for training than the Whipple.
I have a question about remote surgeries. There's lots of hype about remote surgeries or even proctoring remotely. I don't know if any of the 4 speakers are engaged with remote surgeries, and if you are, what are the shortfalls that you felt that you can perceive in doing remote surgeries?
I think remote proctoring is totally possible, but doing remote complex surgery right now, I think there's really no benefit. Forget about all those legal barrier. There's many other potential consequences. There's a very good recent review on this topic in surgical endoscopy. I think it's in press, just addressing this concern. But I think proctoring is totally okay, but doing the real complex surgery is impossible, right?
Yeah, I think remote surgery is kind of very differently placed in different regions based on the medical legal structures and the kind of economies that we are working in. So if I talk about India, a lot of remote surgery is being explored by new robot systems like the Mantra and the Bond Symphony. In fact, next month I'm going to do telesurgery on an animal in China with a console in India. So, this is a remote surgery for a new robot system here. But as Dr. Hay very rightly said, right now the practical application is more for teleproctoring. Uh, but I'm sure that US system is much more difficult to navigate in terms of legalities and the implications for remote surgery. But systems in India is, in countries like India, is not that difficult to navigate. And we would have some potential benefits in many procedures wherein extended teams can work across cities. So if a person who has trained with us goes back and establishes his practice in a smaller town, and then he can be helped at certain steps of the operation by the senior surgeon in some other city who he has trained with, so they are in sync with each other. So I think as companies, especially big companies like Intuitive, don't want to take this liability onto them, but the newer companies are more aggressive about it, and they definitely want to make it happen.
I don't disagree. I think you both are correct in saying that, it's one thing to proctor on a bread and butter case, but it's another thing to say this is a very complex case and I need some senior, highly skilled surgeon from across the world to do this complex. You have to have a very equally highly skilled surgeon on this end to salvage you out if Lord forbid, you were in a complication. And the legal implications are such that it'll be hard to justify what was happening in the operating room. That's great. If anybody has any other questions, please feel free. Otherwise, I know we've gone over our time, but it's been an exciting hour.
Thank you very much. It was really amazing.
Yeah, thank you.
Yeah, thank you. Thank you.
Great. Thank you for joining us.
Have a good day. Good
Thank
evening. Bye-bye.
You all have a very good night, day, morning. Take care. Bye-bye.